Good evening and welcome to Eminent Psychotherapists Revealed. I am very pleased to be able to feature our guest, Dr. Giancarlo Dimaggio, who's a psychiatrist and an eminent psychotherapist who lives and works in Rome. He's at the Center for Metacognitive Interpersonal Therapy, which he is the developer of. And he's going to talk with us about his model tonight as we get into things with him. This metacognitive interpersonal therapy has received empirical support in Italy, Australia, Spain, and Denmark, and it is applied to adults and adolescents with personality disorders, as well as psychoses, which is very interesting, and also eating disorders. He published 230 papers, so he's not only a clinician, he's a scholar, and book chapters, and his books, he has 7 books in English and a few more in Italian. He is the editor-in-chief for the Journal of Clinical Psychology in Session, the senior associate editor for the Journal of Psychotherapy Integration, and associate editor for Psychology and Psychotherapy Theory, Research, and Practice. So we're very pleased and thank you for taking time. I know it's very late in Rome, for joining us tonight for our Eminent Psychotherapist Revealed.
Thank you, Jeffrey. When I listen to your presentation, pardon?
Go ahead. You can say how flattered you are.
Exactly. I was just saying that when I listen to the presentation, it looks like I'm a serious person, which I am not.
Okay.
You're both. You're both. I haven't only hung out with you for a short period of time, but you're both serious and fun.
Thank you. Thank you. But it's most the second part, but I try to be serious.
No, you're very serious and very fun.
Good. So for participants, please use the Q&A feature. So I'll be checking that throughout, and it would be wonderful if you participate and we have comments to present. So I will start with a question. Well, Jeffrey gave a great introduction, and I know many people know the term metacognitive and metacognitive therapy, but Giancarlo, would you explain about metacognitive interpersonal therapy, which you developed?
Yes, I developed with many colleagues from my old center in Italy and with other colleagues in the center where I work now. But actually, metacognition is to a certain extent synonymous for mentalizing. Okay, but when we developed the construct, actually the terms mentalizing was already occupied by the mentalizing folks. So we needed a different name because the operationalization of the construct is slightly different. Basically, it is about understanding mental states and recognizing what we feel, what we think, and making guesses about what the other think and feel and the reasons underlying overt behavior. And this includes the ability to see things from a detached perspective, so to realize that ideas are just ideas. And then the major difference between the term metacognition, the way we use it, and the term mentalizing, and that we have a separate axis for what we call metacognitive mastery, which is psychological knowledge for the sake of purposeful problem solving. And the core idea is that the first thing that you have to do with patients, in particular severe ones with personality disorders and psychosis, is to help them develop their capacities to think in terms of mental states, and then use these more and more nuanced capacities, more and more, so to say, mature capacities, in order to soothe suffering and solve social problems. So that's the core of the meaning of the term.
So one of the things that I find in my work with personality disorder patients is that the capacity for metacognition or mentalization is very different for different patients. Some patient, and to me, and tell me if you think this is accurate, but to me, being able to know which patients have a low capacity for it, as opposed to ones that have a bit of a higher capacity for it, totally changes your treatment orientation. In the low capacity patients, to me, it seems like my major function is engaging them with curiosity and being able to help them find and articulate terms. We used to call it psychological mindedness.
Yeah, that's similar.
So is that kind of how you see it? Like there are patients at different developmental levels in their ability for metacognition, and part of the art and science is to match the therapeutic stance to where they are. And if you could say more about that.
Actually, it is one of the core abilities that a clinician treating personality disorder needs to develop. We need to continuously monitor the level of metacognitive capacity of the patient in the moment and try to build the next step. So continuously working, so to speak, into the metacognitive zone of proximal development and never move to a higher step, otherwise the therapist is alone. And very often we have patients, just as an example, with avoidant personality disorder, and you ask them how they feel, and they just don't know.
Yes.
They feel tense, they describe behavior, they say, I don't know, I'm nervous, I'm down, interaction are difficult, and the only thing that you have to do is continuously be curious and asking questions about what their experience is, and maybe suggesting that there can be a specific emotion, of course, always trying to get them in touch with nonverbal markers. So you look, okay, you are tense, but your face is so and so, maybe is that shame? And so you scaffold metacognition continuously. At the same time, low levels of metacognition are an important marker for things that you don't want to do. I have a very recent example. I'm seeing a patient for 9 sessions, so quite the treatment just started, and he's a very nice person, I have to say, but he's a pretty much an overt narcissist. Pretty nice, absolutely, and he's having conflict with his wife, and he never remembered the reasons. It just tells, we had a lot of argument. Okay, but what happened? I don't remember. What was the reason? I don't remember. So that's poor metacognition in terms of poor access to mental states. He doesn't remember. He doesn't remember episode, and autobiographical memory is key to exploring mental states, but he doesn't remember episode. So I asked him to bring the wife in because I needed more elements. And she came, and I discovered a lot of things. For example, he was sometimes physically aggressive. And his wife remembered some episode, and quite honestly, he didn't remember. And it was clear he was sincere, nothing really serious, of course. But another thing that really was surprising, that while telling the story, his wife was scary and sad. And her face was so clearly full, displaying fear and sadness. And he wasn't reacting. And I'm pretty sure he loves her. He's affectionate, he cares for her, that there's reciprocity in that. But I asked him, but please, how your wife is looking in this moment? And he said, I don't know. And you don't see what's in her face. And his wife was totally astonished. And he said, I know. And in another moment, she was crying. I asked him again, how does she feel to him? How does she look to him? And he said, picky. So like she was criticizing him, and she was in tears. Okay. And that's a major example of a failure in understanding the mental states of the other, even in the presence of visible cues. Okay. So this is a very good marker of things that I don't have to do in the session. Okay. I cannot ask him to change his behavior until it doesn't recognize the reason.
Until it registers what he's actually doing.
Exactly.
Yeah.
Exactly. So the next step was I gave a kind of a homework to both. So to monitor what happened and report them in the next session. Mostly I see him alone. I only saw him with his wife another time. And the next session, things were much better. He was much more self-regulated. They had an argument and he remembered him. He remembered that. So he remembered they had an issue. He remembered the story. He remembered the motives. Okay. So in a good relational atmosphere, his metacognitive capacity has grown to a certain extent. And they were better. Okay, so that's an example of failure in understanding mental states, in failures in understanding the mental states of the other, and on how do you have to attune your intervention to developing what is not yet there.
Yes, yeah. So now, is it possible that a patient can have a highly attuned mental state, understanding of another person's mental state, and have very little understanding of their own?
Well, actually, it is more often the reverse. Okay, and very often when they are so much, they can be able to describe what's in the other person's mind, but actually is many times is kind of projective.
Projection, yeah, okay.
Yes, and other times is self-serving. So I'm monitoring your states because I have to see if you are going to abandon me, if you're going to cheat me, if you're going to hurt me. Okay, and then there is awareness of own feelings. So they over-mentalize on the other, but because they are worried about their own feelings. Okay, so actually in terms of therapeutic techniques, we always try to first develop first-person metacognition and then move to develop, so to speak, a theory of mind. Never the reverse.
Never the reverse.
No, we never try to build an understanding of the other. Maybe that can be a difference, for example, between what we do and what mentalizing-based therapy do. We never try to make them mentalize on the others. It's always, okay, but what's the impact on you? Okay. Because otherwise they can be resort to theorizing and sometimes it becomes self-invalidating. So they try to understand the other and they fail to recognize the reasons they are suffering for. And maybe that's the other part of the therapy. It's metacognitive interpersonal. Okay, so interpersonal means that patients with personality disorder mostly suffer from their predictions, which is the schemas. That is, they have expectations that their own core evolutionarily selected wishes, such as attachment, autonomy exploration, social rank, group inclusion, sexuality, and cooperation, they will remain unmet by the other. Okay, so they have a set of prediction based on core ideas of themselves. For example, I want to be valued, social rank. I have the idea that I am flawed and inferior, and I predict that if I show what I did, the other will humiliate me, criticize me, because they're right, because I am unworthy. Okay, so the very goal of therapy is help them realize that they are suffering not because of what the others do to them, but because of their predictions. Okay, so the first step is developing awareness of the schema. Once you have developed the awareness that you have a schema, how it is shaped, then we can move to form a more nuanced understanding of the real other.
It's so interesting that you're bringing this up today, because I was working with a psychiatry resident in supervision this week, and he had a patient that was unable to describe sensations, emotions, and yet the patient was behaving in such a way that it was so obvious that the patient was like describing the ability to connect with someone else, or describing grief that was welling up inside.
Yeah.
And I said to the resident, why don't you just name it? Like, why, okay. And like, why don't you just name you're connecting right now, or you're grieving right now? And he said to me, no, I can't do that. I'm not allowed to lead the witness. I'm not allowed to lead the patient by naming. And so I would love for you to talk about that if you can, because, you know, for me, when someone has a deficit, you begin, you know, just like a mother or a father would, just naming, like, you're sad right now, you're happy right now.
Yeah, exactly. I totally agree. Actually, you know, there are misconceptions about what psychotherapy is, and sometimes it is about, you know, maybe I'm too hard here, but it is based on outdated models, or some kind of moral prejudice. And if patients are unable to name their experience, it's not just because they don't want to express it, but because they don't have the capacity. And how is the capacity to name mental states and communicate to others shaped during development? As you said, Christine, is shaped during childhood through interactions with parents. You have to develop what is called it's called maternal mindedness. Of course, it's both the mother and the father, by the way. And so it's trying to see what the child is experiencing, fear, anger, and welcome it. Oh my God, how are you? Are you scared? That's normal. And that's the way children learn emotional language. Through they mirror their experience in the eyes of the other. And if something went wrong during their development, they are not able to discover feelings on their own. They didn't learn them. They didn't move the basic steps. So the therapist must scaffold that ability. And then there is another, maybe someone would object. Maybe you are controlling the patient, or they will just answer out of compliance, out of the need to please you. But that's not a good answer, because if the answer is sincere, you have nonverbal marker. You see there, okay, no, that's fear. If they answer out of compliance, out of submissiveness, you see it. They don't change their expression. They don't make steps. They don't change their behavior. So you just continually monitor the therapeutic relationship. And in a way, you have a lot of signals that help you discover if their answer was okay, was, so to say, sincere, or was forced by your help.
Isn't that what we call attunement? The capacity to be curious and interested and fairly accurately reflect. I think that's what you're talking about, Kristen. Fairly accurately reflect back what you're seeing non-verbally. I don't see how that could be bad practice. That seems like what we do.
Exactly.
That's exactly. You know, a lot of times when I had patients that had these kind of early attachment disruptions and trauma, I will show them the Edtronic still face video.
Yeah.
As a limbic probe, because I can see how they react sometimes to it, and also that just to show them the power of what happens when a maternal figure, her face goes blank for a minute, how that kid gets, a year-old kid gets so emotionally and physically dysregulated.
Absolutely, absolutely. Yes, actually, therapeutic neutrality is still face, and it's dangerous.
Yeah, I agree.
It's just disrupt metacognition. Yeah. It disrupts consciousness in a way.
Yeah.
Children dissociates at a certain
point. They don't
point.
Feel safe without that.
Yeah, absolutely. They don't feel alive even.
And so I think what you're describing, I would call engagement, like you're
Yes, exactly,
engaging,
exactly.
that if you can't engage the person where they are, wherever they are on the developmental path, there's no hope for mentalization.
They won't do it spontaneously. If you have, for example, a 25-year-old man with avoidant personality disorder, he would never be able to mentalize on his own because he didn't develop the skill, he's ashamed, he avoids, so he will never be connected to his own feelings spontaneously. You have to be continuously focused on their experience and in a way put some pressure. That's good. When your pressure creates some strains in the therapeutic alliance, you focus on them and you bring them to light and talk. Am I too pressuring? Am I too domineering? Am I disturbing you? You feel control? Just tell me.
Yes, yeah.
I love that. Yeah.
So in a way, I hear a little bit of ISTDP there, and a little bit of it, but engaging the person in the process, being real with them and responding to them.
Exactly, exactly. I think that corresponds to their practice. I agree.
Well,
You're
and what
speaking my language.
Yeah, mine too. And what I loved hearing is how you offer an intervention, like for instance, mirroring, and then you watch for the impact. Like how is the patient going to respond to this intervention? And then that tells you, what was it the right intervention? Are you assessing this correctly? Like just their response will allow you to know like what to do next and how to move forward. Yeah.
Exactly. I fully agree with both of you. The majority of my supervisees are very concerned about their own action. And I say, your action must be based on case formulation, but actually you need to be focused on the next step. So you act, and then you have to tailor your intervention on how patients react. And that's the information you need. So be worried, but to a certain extent, because then you correct yourself on the basis of patient reaction. And so you have a lot of room to do a lot of things, because you can make small mistakes, medium mistakes, but you always control yourself through the lens of the patient's reaction.
That's right. Yeah.
I love what you're saying. Having taught for many years, it's like students always have this concern that I'm going to say something wrong. I'm going to say something, that will destroy this person. And I you put into words, I say, like, if you monitor the person's reaction, you can always repair and get back in tune. So
exactly.
I like that you said that.
Yeah, and Barbara is expert with case formulation. So the minute I heard you mention that, I was like, oh, she's well versed in that subject.
That's my pet phrase.
Right, Barbara has
specialty.
one of the best books on case formulation.
Absolutely.
That's great.
Yeah,
that's great.
And you learn like case formulation really is the compass for us. Like it helps me, but then if I'm able to say it out loud, then it helps my patient. And then it also helps when I do use an intervention and I get to see, okay, did this work or not and why? And it's very helpful.
Yes. Oh, sorry. No, please continue.
No, I'm good.
I just want to insert again with students' questions and concerns. I'd say, what should I do in this situation? What should I do? And I always say, well, it depends on your case formulation.
Exactly.
Is based on this unique individual and not based on some theory.
Absolutely. Well, consider that we are trying to build evidence base for our model, and we have of note. We just had a new paper from Norway, another author, and it comes from Teresa Wilberg and colleagues, and it's about combined metacognitive interpersonal inspired therapy, because they were not following the manual, but I supervised them, with mentalization for avoidant personality disorder. So another recent one and very good. And for avoidant personality disorder, and I jokingly say it's a Norwegian avoidant personality disorder, which is a bit more. I love Norway. I'm
Special
almost,
flavor.
I'm almost. I almost have the Norwegian citizenship. I want to say it, but they are very avoidant. Okay, and results were good, but more in general, and we have combining overall the results of the outcome studies we published so far, and the one on eating disorder is almost completed. We have kind of a 10% dropouts, which is very low in the field of personality disorder. And of course, we really need larger numbers, but that's the trend. And I say, if things will be confirmed, so of course, let's cross fingers. So if it is maintained when samples grow, and probably it is because of the way we make the case formulation. And because we always try, we on the one hand, as Barbara said, case formulation is ongoing. You don't do it in session 1, 2, 3, 4, and that's done. It continuously changes. You have to update the model.
You're refining it as you go.
Continuously, every session to a certain extent. And second, a case formulation must be shared. I say, what's in your mind as a therapist doesn't count anything. Your ability is to help patients develop a conscious model of their own functioning, and then become willing to use that conscious model of their own functioning for the sake of change.
So collaboration, you're saying, is key.
Continuously collaboration.
Right? And adjusting that as you go, and making sure you have buy-in to what your case formulation and your theoretical
that you are on the same page.
Yeah,
that
and
you and the client.
Yeah, I think there is some evidence that I read recently that is actually one of the common factors across all psychotherapies, having the patients that we work with buy into our formulation.
Yeah.
If they don't buy into it.
Yes, exactly. I have to say that, I probably the thing I do most in my private practice is supervising people. And I have colleagues from many orientation, mostly of cognitive behavior therapies, but also psychodynamic, systemic, humanistic, and they mostly do the same mistake. That is, they focus on their own formulation, and they don't realize that the patient is not into that. So they continue to push, and they don't realize they are alone. So my most frequent intervention during supervision is check explicitly with direct open question what the patient has understood of himself or of herself. Okay, and then you know what the formulation is. It's not about, and the answer I say to the patient, it doesn't matter what you said to the patient. It matters what they understood and what they made their own. That's the basis for further work.
Absolutely, yes. Now you sound very integrative as I hear you.
I think I hope I am.
You are very integrated. I can hear all these different blends.
Bing, bing, bing.
Yeah. And that's wonderful. But I'm really interested in what you think about. You're such an engaging human being, and a lot of therapists don't come by that naturally. So what do we do with therapists that we're training, since you do a lot of training and supervision, and we're trying to figure out how to train the next generation of therapists and transfer the expertise? Talk a little bit about, like, were you born like this, and can we train people to be engaging, or is that something like is a necessary therapeutic component?
Well, actually, you're right. I'm very open and talkative. That's natural.
Not just talkative, but engaging. You have a
that's me to a certain extent. But for example, in my case, my training, my unfinished business were more about self-regulation. So to enter less during the early year of my career, I was too much in the room. I wanted to impose my ideas. I want to show that I'm clever.
Yeah. Yeah.
And then I fought with the client, by the way,
Mhm.
because they disagreed. And why they disagree? I said such a brilliant thing. And I had dropouts, I had alliance ruptures, and I was totally stupid and unable to repair. And then I had to learn to become stupid.
Yes, what I think the most interesting thing that on this topic that I read about and I've learned is that the things that we think are the brilliant things that help patients change, when you go back and interview them later and say, so what was it about working with Dr. Dimaggio that was the change agent? He said, you know, one day he just gave me a hug or something, or he offered me a cup of coffee, and he
For example.
and it's like, and that's what, but it's that relational component
Yeah, yeah.
that seems like, how do we help people with that? Like, how do we, yeah, I get that at one point you were over excited. And
Yeah, exactly.
I started my career out the same way, so I identify with that. But the engaging factor to me is so key.
It is very important. Actually, there are so many entry rooms. We need to learn to be engaging, starting from who we are as person. For example, I have colleagues, maybe women that are more, you know, a bit more shy, but have a touch of gentleness, or they are more able to nurture patients to a certain extent.
So different characteristics can be used.
It can be used, exactly. Yeah. But then you need to overcome your limits. That's important. So I have to develop more caregiving if needed, because the case formulation requires it. And I have, for example, to learn to be more, to use more humor, to be less polite, because it, for example, I was supervising a colleague of mine. She's very bright, but very much self-control. Okay, and she was seeing a young patient with narcissism, and mostly covert narcissism, so avoidant behavior, but covert narcissism, and sessions were completely useless, because he entered the room and he was so polite, and, well, doctor, how many books you have you read this? I have read that one too. And so it was kind of a ballet, and there was no contact. And my colleague said, I cannot step in abruptly because I want to be respectful, because it is my core value. And so I had to work for a couple of supervision sessions, helping her to say that she has very beautiful moral values, but they are not useful to the patient. She needed to be more, and I don't have the term in English
disruptive,
now.
Disruptive.
More disruptive, more,
the defenses.
Yes, it's like she needed Ricky Gervais in the room in that moment, for example. And we of course we worked on personal material also. And then the next session, she gently said to the patient, well, we are so kind to each other, but does that help? Because because I realized I'm too gentle. And so she started to use humor. And at a certain point, she did a very nice thing. She sat on the carpet, so like playing with a child, and used a set of flashcards and asked the patient to name his different self-states. And he was able to articulate his own experience, and he was true in that moment.
She engaged him.
She engaged him, but she had to overcome her limits.
Yeah.
So her respectfulness maybe would be more useful to different patients. Maybe I would be too much for them. She would be good for them, but with that patient, that wasn't working. So she had to overcome her limits. She did, and believe me, the next session, it was like listening to a completely different patient, much more open, much more able to articulate his own experience, less ashamed, because of course shame was his core feelings he was trying to protect.
It sounds like she was willing to be vulnerable with him. Like she did it first, and then he did it next.
Actually, she wasn't. She accepted that he could hurt him because she was overprotecting. She thought that she had to be very respectful for a lot of personal reasons, but actually she was protecting herself for a serious issues. That, yes, but then it was about accessing her own vulnerabilities. We saw them in the next supervision session. Absolutely.
Right.
Yeah.
So she was able to work through it with, I'm just, for the audience, I just want to say she was able to work through it with you in supervision. What were her blocks?
Yeah.
And then she brought it to the session, and then that's what unfolded is what I'm hearing. Yeah.
Absolutely.
Yeah. Go ahead, Barbara. Yeah.
I just want to say it's clear how much benefit can come from supervision and how transformative it can be for clients, for therapists rather. But imagine that doing, they're applicants for a job or entry into a training program, and you have a chance to meet with a lot of prospective therapists, more than you could hire. What are some things you would pick up where you would say, no, this person is a good learner?
Defensiveness. I always say to my supervisee, I don't mind you make mistakes. You make mistakes, I'm happy with that. You are not able to deal with that patient, I'm happy with that. What I need is that you are open to see what is not working, and I need you to access your own story. I don't want you to tell me your story. I'm not your therapist. But when you have a patient with borderline disorder, narcissism, avoidant, obsessive compulsive PD, paranoia, of course they can elicit many aspects in us. We can become scared, self-judging, ashamed, worried, useless, irritated, annoyed, whatever. Okay, and this creates vicious cycle in psychotherapy. And you don't break them focusing on the client. You need to realize that you are not seeing the client. You are seeing some ghost in the room, something from your own story. And I don't want you to know your ghosts, so to speak, of course, metaphorically speaking. I want you to see them. So I need to be free to ask you, where does this problematic episode you're having bring you? Are there any memory? And I'm happy in the moment I see that in your eyes, you are seeing something. I'm not speaking of a visual hallucination, by the way.
I know.
It's memories popping up.
Yes, yeah.
And when they are able, okay, I can see it. I say, if you want to say something, I'm here, but I don't need to know your story. I need that you realize that the problem is not the patient. The problem is not the technique you're using, but the problem is that you are irritated, scared, worried, whatever, for something that is personal. Then you overcome it, and then you're connected. That's the quality I need.
Don't you think, though, that another aspect of that, I think you're talking about what we say transference, countertransference, and
yes,
I think another aspect of that is that, especially with the personality disorder patients that I treat, is that they are pulling from it. Doesn't necessarily mean you have unresolved issues, but sometimes it's that it's what I call a reenactment. They are so convinced that you're judgmental, you're authoritarian, you're impotent, that you're like, I have a patient I was working with today who I've been working with for a long time, who has had very early and chronic trauma. And he does not believe that anyone in the world could ever understand him or help him. And this comes from his childhood code and schema. And so when he brings that up, I say, so it sounds like you think I'm like a totally useless therapist to you. So that's really interesting. Like, why do you think I'm such a useless therapist? And then he laughs and he starts, and then he can see like how much he wants me in that role because his father was incompetent. So
Yeah.
he's always inviting me to give him suggestions and then to say, but you know, that will never work with me. And I keep saying, okay, I'm your daddy right now. And he's like, oh yeah. And so,
Yeah.
so it seems like a lot of that pull is trying to reenact and bring alive, which I think is what therapy is about. You're bringing alive in the set in the room. You become the shadow person of the relationship, and which I think is so curative when we can work with that.
Absolutely. Now you are more referring to what is more real counter-transference. You are called into the room to play something that is in their story.
How do you differentiate the like things that are unresolved in me that are being activated and things that they're so actively projecting that, you know, they want me to reenact something with them?
Well, it's a nice question. I just have a pragmatic answer. And if the therapist is able to modulate his or her reaction and then move to, again, case formulation. So what is needed now for this person in this moment? I don't have to elaborate their own issues. Okay, but if they still remain tense, defensive, or they continue to worry what is the right thing to do, then it's probably personal material. It's some kind of unfinished business, you know, Hoover in the room.
Thank you.
So as long as they are able to do the right thing, be consistent with the next step needed in the therapy according to the case formulation, no need to elaborate further into therapist's personal matters. Yeah.
I have another question.
Yeah.
Is there anything new in the field that you're excited about and that you would like to talk about?
Oh, thank you, Barbara. Actually, this is the thing I love most. And, you know, I wrote a book in Italian. I couldn't have it translated in English. And it's called The Moment Before the Fall. And the subtitle is The Experiential Revolution in Psychotherapy. And but actually, I'm more and more focused on experiential techniques, something that is coming from the story, from hypnosis, Pierre Janet, Jacopo Moreno, Fritz Perls, the Gestalt movement, and which is now entering the empirical, the evidence-based, empirically support psychotherapists. And well, actually, the core idea is that patients, in particular personality disorder, serious traumatized patients, and psychosis, but mostly personality disorders and trauma, suffer from the schemas. But the major part of the schemas is stored in their memory at an implicit level. Okay, so they are driven by automatic processes.
Yes.
And actually, it's very hard to change them just talking.
Yes.
Okay, and what we have to do is to really make memories again alive in the session. I always use a kitchen metaphor. You need to raise the temperature of the oil, because if the oil is not hot enough, you don't fry anything. Okay.
Yeah, that's good.
And with frying, I mean transformation of the structure of the memories.
That's
Okay.
hot.
I think that's a beautiful, I'm going to use that metaphor. That is a really helpful metaphor. So one of the things that I've been interested in working with my patients that have early trauma is, and I don't know if what you're talking about you would agree is a similar kind of concept, but I call it a state memory, STATE. So the person has no narrative memory, so it's implicit, no narrative memory, but they
helplessness.
It's like a combination of non-metabolized, undifferentiated feeling.
Yeah.
Say they were left alone in a room for hours as a kid, and they had all that feeling.
Mhm.
And usually, so tell me if you think I'm on the right path here. So
Mhm.
usually when I'm working with someone, once I do my assessment and I'm working the case formulation, I'm trying to find, is the pain coming from their current life?
Yeah.
Did they have marital conflict of a kid? And if they say no, but they have this terrible states, then my heuristic is that sounds like it's a state memory. That is something, an implicit memory
Mhm.
that's a key to us, that there's something there that you may have no mentalizing, no verbal capacity, no narrative memory for. Is that sound?
Yes, absolutely. There are two issues. Sometimes you have memories, but you have to let them relive in the session in order to transform them. So you need to increase the level of arousal. So therapists really need to learn not to be overprotective. I think that's one of the major mistakes. It's failure by omission. We don't do enough. We're trying to protect the patient, but it's not needed. They have their own defensive processes, and they use it pretty well.
So are you talking about the optimal window of anxiety that so many of us talk about, that there's a certain, if it's too low, you get bored, and if it's too high, the patient's flooded, but in that optimal window there, that's where the oil is at the right.
So and so, because we try to bring them a bit out of the window. We want them to lose control to a certain extent. And because if you have traumatic memories, but even not traumatic, but very disturbing memories, you need that arousal is similar to the original experience. And then you help them with true rewriting. So you need to be somewhat brave to do so. And it's safe.
I tell some of my patients that, and I think that most of the personality disorder patients we see have a history of unprocessed trauma. I think that's the pathway. But what I tell a lot of my patients is that this kind of therapy is in a way controlled re-traumatization. If you don't bring the trauma alive, you don't bring it all alive, you can't
you don't solve it.
transform it.
You don't solve it, and there is evidence for that. Exposure-based therapies, of course, as delivered by skilled therapists, are safe. They are effective and safe. The myth, we have to protect our patients from re-experienced memories because they will dysregulate, and no, it's a myth. Side effects are very rare. There is recent research saying that very clearly. We need to expose it. Then, if you have patients, they have unmetabolized material, then you work through the body. Okay. For example, patients have some kind of disturbing feelings, sometimes of dysregulation, but they don't know why. They feel scared, ashamed. For example, I ask them to, step up. I ask them, for example, at the first step, to knee and to bend and to say like, I'm unworthy, I'm a failure. And I want to feel it. I can even say it pretending that I think that. So they need to suffer, because for a moment, they need to think that I am real in criticize them. Then I ask them, okay, now raise your head, open your chest, and say, I worth something. How does that sound? So I let them embody different states and express different self-ideas. And then I ask them how their experience changes. So they start to discover out of experience in the session that their ideas about themselves are not facts. They depend on their bodily states. This is learning out of experience, of experiential techniques. And in my practice, you don't get so easily just talking. You need to let them do something, and it's very powerful.
Yeah, this really resonates.
I just want to say, excuse me, Chris, I just want to say that we have about 10 minutes left. And I just want the participants to know that you can use the Q&A if there's a comment or question. And also when the recording is over, we continue to hang around here and we're open for informal dialogue. Continue.
So thank you, Barbara. So, you know, a lot of times I'll tell my patients it gets worse before it gets better. But
Yeah.
what I've noticed is before change happens, the resistance rises so high that I feel like I'm either going to get fired or something is going to go off the rails.
Yeah.
And I'll even leave a session sweating if it's not resolved then, and obsessing. And in the next session, that might be where the resolution happens. It might not be in that one session, but it's happening very soon. And sure enough, like when they break through the resistance, it's like everything's different after that.
Of course,
And
of course.
it's beautiful. I mean, really beautiful. So,
Exactly,
yeah.
Kristen, and you know, turning back to your question about, you know, scaffolding patients in experience in naming their feelings, this is another element in which the therapist must be clear. If you don't try and behave differently, you won't change. You know, that we need to be realistic. You can choose not to behave differently, but then we have to agree that, you know, my power to help you change is limited.
Mhm.
But then they have to understand that the first thing that happens when they try to expose themselves to previously avoided behavior, emotional pain is there. For example, you never solve any kind of guilt, moral guilt, survival guilt. You won't overcome it if you don't accept to be mean and to run the risk of making other people suffer. You won't heal. You will
Right.
always pray to protect the other from your own independence.
Right.
And there, I never find a different way other than trying to experience guilt, which comes there and bites, because guilt bites always, but then be consistent, be attuned to your real need, and move on. But this means experiencing pain. It's distressful.
Right. Right. And I find it's always in their hands. Like
Yeah.
there's just this moment of like, okay, this is your resistance. This is your suffering. This is your pain. I'm going to witness, right? And I'm going to be here. But when you gateway, right? It takes on this motion all of its own, and it's completely
Exactly.
theirs.
Absolutely. Absolutely.
Beautiful. Yeah.
And these are the most difficult moment for the therapist, because sometimes patients don't want to make that step. And then I use a term which I means, it's hard to translate it in English, is impotence, but moving towards the patients. I show you that I am powerless.
Yeah.
But I'm moving toward. But I'm powerless and connected. Yeah. Okay, you decide not to expose yourself to that one. I understand you.
Right.
I'm just asking, how can I help you change? I can witness your pain. I'm here. Don't worry. I'm not saying that therapy is not working. I'm here. I'm just, how can I help you? And it's hard for therapists to embody this sense of powerlessness while remaining here without criticism, without frustration. But if you are able to embrace this position, then you can promote change, because patients understand, okay, I'm on a crossroad and they have to decide, remain in my safe area or decide to explore the world. And they get it, most of them. Then if they have, kind of 5 personality disorder diagnosis at the same time, probably they won't follow the path of liberation. But the therapist is able to remain there and stay without, doing further damage, accepting that they won't change, but we can be present for them.
Yeah, and that's where that case formulation comes in, because you just bring in the formulation, say it out loud, and
Exactly.
and it's very powerful. And there are some small changes that happen
Exactly.
just in that session.
Absolutely.
Yeah. Beautiful.
Mm.
I like I'm getting the interpersonal of mentalization here. It's like, it's really being in the relationship with your patient.
Completely. But
In a way,
always be active.
But isn't it really reparenting? I mean, really, I mean, we're taking someone developmentally who had some kind of traumatogenic attachment issues, and we're modeling and we're tuning and we're doing a lot of the things that a good parent does, a good mother and father, and we're giving them a corrective emotional experience.
I fully agree with corrective emotional experience. I agree a bit less with reparenting, but it's not that it is wrong, but it is too much attachment bound. Okay, and while we need to be attuned to different core evolutionary based motives. Okay, so for example, when you are in the realm of competition, you have to avoid adopt the position of the parent, because it's there's a power imbalance there.
No, I agree with you. I'm not talking about the parent function in terms of that kind of attunement that you're talking about.
Yeah.
That is the corrective emotional experience because so many of the personality disorder patients have attachment trauma. I mean, that's
absolutely.
It seems like it's if they usually have lots of other big T traumas and so forth, but it's almost always there's attachment trauma. There's some over the narcissistic disorders and so forth. So this is great. This is really good stuff.
But actually, sorry, just one question. When it's about treating personality disorder, so to speak, during the first part of therapy, you walk through the therapeutic relationship, you repair the therapeutic relationships, you provide ruptures and then corrective emotional experience, absolutely. But then from a certain point onward, what I see is that the majority of the change needs to happen outside of therapy. So it's continuously about behavioral experiments. If patients don't try and bring therapy home and be active, they won't make further progress.
Yes.
So every session, except for the ones when you gain great insight, intense emotions, reappearance of painful memories and elaboration of painful memories, but with the exception of those very important moments, and the sessions ends with, okay, we understood this and this during our conversation today. How can we use it in your life next week? So it's continuously focusing on the future. Otherwise, patients will remain in a state of self-reflection, which means rumination and worry. While instead we need to plan new actions continuously.
And Jeffrey, I obsess about that topic, and Martha Stark has these levels for therapists, level 1, level 2, level 3. So I've decided it's called object relations coaching. That's the way I approach it. Just, in and out as necessary.
So we have another minute left. Is there anything you would like to?
There are 2 questions I see.
We'll get to those afterwards. Can I just?
No, I will say. Oh,
we only have a minute left, and then we'll do the questions afterwards. So hang around, but
Lisa, please hang around for afterwards.
But one question before we sign off. What would you say to young therapists is the most important thing for their journey?
Study a lot and be curious and be brave. Don't try to protect your patients. You never be patronizing, but don't be scared. Experience, try and see their feedback. Clients tell you, patients tell you, if you don't do the right thing, or you're doing harm. If you do harm, you have a lot of room to adjust, repair, and fix. If you remain too much in a safe zone, change what happened.
Dr. Dimaggio, thank you very much. It was such a pleasure to have you. We're going to hang around for a couple minutes. We're going to stop our recorded version, and you can pass it around to your friends who want to watch it and your colleagues. But come back next month for our next program. Thank you again, and we'll see you next month.
Thank you.